Hello, welcome everyone. Thank you so much for attending on Thursday evening at 7 p.m. We're here for a really exciting BGCS webinar on the quality intervention from the National Ovarian Cancer Audit. We're really hoping this can be as interactive as possible. I'm chairing the session. My name is Sudha Sundar. I'm Professor of Gynae Cancer at Birmingham. We've got an illustrious panel. Aggie Michael, who is the oncology lead from the National Ovarian Cancer Audit, is going to be speaking on the recent results and why we've chosen this indicator for the quality initiative, a quality improvement initiative. Georgia Zaku, who is the NOCA clinical fellow, is going to speak about a QI intervention that we are developing. There will be one big QI rollout that happens in September later this year, but then we'll have a focused QI intervention that's going to be developed and that will then be evaluated in a robust methodological way, perhaps in the next year. So we really look forward to hearing from you in terms of your thoughts. We'll then have a panel session between two of our extremely well-performing cancer centers. We're delighted here today to have Saurabh Fadnis and Rowan Miller from Bath, who in 2024 from the State of the Nation report were, I think, the best performing cancer center in the UK. So that's really lovely to hear what has worked for them and what we can learn. We'll also have Richard Edmondson from Christie, who is, I think, number 2 on the leaderboard. So that's, again, a really good opportunity for us to hear. And this is all about sharing best practice. The leaderboard isn't fixed, by the way. It kind of rotates around. So next year, there'll be a different roll call. But I think this is good, though, because we need to have a churn so that, so it stays, because we're all competitive people, and that's the sort of thing that drives us. We'll have Miriam then speak. Miriam is a subspec trainee from Bath, and I'm delighted to hear that our subspec trainees are really keen and to move things forward. So we'll hear from her about a new pathway they've got for expedited diagnosis at Bath, and a little bit about what's worked on the ground to really, from a trainee perspective, how to move things forward. Then we'll open the floor to questions. So we can hear then from you in terms of what you think may work for you. I will be upfront. We are looking for 5 to 6 sites. At the moment, maybe 2 or 3 sites to participate in the pilot of our QI intervention. So I will be keeping my beady eyes on the Q&A. Before I hand over to Aggie, a couple of housekeeping points. This recording will be available on the BGCS website at the end. If you want your CPD certificate, please complete the feedback form. Please put in all your comments in the question box, in the Q&A box, because that I can see and can call out for. If there's something that you really want to say rather than just do on Q&A, either ping me or make it obvious on the Q&A that you want to speak, and if it's possible, we'll bring you in. So with that, I will hand over to Aggie, and Aggie, floor is yours.
Thank you very much, and thank you for the introduction, and welcome everybody. I'm not going to go through introductions who we are. I think, well, we've had a previous webinar, but this is our team. It's a team of Georgia, can you go further up? Okay. So this is a team, so 2 clinical leads, and we've got a team of data scientists who are helping us, as well as 2 students and project manager. Next slide, please. So just to put everything into perspective, I'm just going to go very briefly through the NOCA results from National Ovarian Cancer Audit from last year. The new audit will be coming out soon, but you should be familiar with this set of results. So as you know, it's about 6,000 women diagnosed between England and Wales. So last year, well, from the last audit, which was done on the basis of 2021 in England and 2022 in Wales, we know that the number was about 5,700 in England and 300 or 293 in Wales. And we had 4 performance indicators. Performance indicator 1 was emergency admissions, which essentially showed that approximately 4 in 10 women had emergency admission 28 days prior to diagnosis. Then performance indicator 2, which was looking at treatment, and that showed that only 3 in 4 women received surgery and or chemotherapy. So essentially a quarter of women didn't receive any treatment. Performance indicator 3, which is receipt of platinum-based chemotherapy, which as we know is a standard of care, showed that only 2/3 of women received this treatment, which means that 1/3 again didn't get any chemotherapy. And performance indicator 4, which was looking at 1-year survival, unadjusted figures showed that 7 out of 10 women in England and 3 in 4 women in Wales survived at least 1 year after diagnosis, or if we put it the other way around, that means 30% of women didn't. So the figures are really very poor. So as every audit should do, the drive is to now develop quality indicators and improvement, quality improvement scheme on how we can improve on the data that we showed basically. So the natural choice, one would think, is to do something about the emergency admissions. So the initial thought was, you know, how can we reduce the number of emergency admissions? But I'm sure you'll all know and realize that this would be an extremely difficult indicator to work in. It's very important because we know it's the most important contributor to short-term mortality, but at the same time is not within our remit to a large extent because it is dependent on many factors. So it's delays in diagnosis, not necessarily, I mean, in primary care and secondary care, and a whole range of other factors which would be very difficult to work on. So the next best thing we thought is to focus again on emergency admissions, but on what happens to women in the first 3 months after emergency admission and diagnosis, because we do know, and we'll show you that data, that this is really important in terms of the overall outcome. So the advantage here is that we have a lot more control over that, because once women have been diagnosed and are admitted as an emergency, it's in our hands to then make sure they get the treatment. And it would be obviously, hopefully easier to work on that. Georgia, next slide, please. So when you look at the emergency admissions only, the figures for treatment are obviously even worse. So only 4 in 10 women, so 40% of women, well, 40% of women had emergency admission, but 60% of them received treatment, so even less than obviously the overall population. And if you look at the variation between the country, as you can see, there is a lot of differences between the centres. If you look at the centres, it doesn't really depend on the number of patients seen, but you can see that there will be some centres where there is about 30% of women that present with emergency admissions, and there are some other centres where you've got over 60% of women presenting as emergency. So obviously a big difference and a lot of variability. However, what's more important is what impact it has on survival. So the blue line here are patients who are diagnosed not as emergency, so go through normal diagnostic pathway, whether it is from 2-week rural clinics or any other route. Admission, diagnostic pathway is in the outpatient setting. And then the brown line is the emergency admissions. So you can see that the 12-month survival here is only 50%, whereas if you compare it to 12-month survival for women who do not present as emergency, the survival goes up to somewhere between 80 and 90%. So a massive difference, and that's why it's really important to focus on this group of patients. Next slide, please. So as I already said, only 59.5, so only 60% of women diagnosed with ovarian cancer within 28 days of emergency admission received any treatment within 3 months. So 40% didn't. And again, if you look here at variation between various gynecological cancer systems, so that's cancer center and cancer unit, again, you can see there are very big differences. So we've got some centers where only 30% of women receive treatment, and we've got other centres where over 80% of women receive treatment. Why is that important? Georgia, it's because of that particular graph. So if you look at the association with survival, that's really, really important. So here we've got receipt of treatment for women who have emergency admission. And as you can see, the more women receive treatment, the better their survival is. This is 1 year survival. So more or less every 10% increase in the number of women who receive treatment within 3 months following emergency admission equals to about 8% increase in survival. So I think, you know, this is something that we really have to focus our effort on, and this is where hopefully the quality improvement is going to make a difference. Next slide, please, Georgia. So how are we going to approach this problem? Well, we're going to have to give feedback to everyone. So all cancer systems, gynecological cancer systems, will be notified what their performance is, and we will obviously disclose the data in comparison to national average and in comparison to the best performing centres. And then we want to propose a sort of resource or a sort of package of measures that could work. And this is partly where you come in as well, because this is where we would like to have the sort of brainstorming session to see what works for whom and how can we adapt those measures. The things that are simple and that we've already put here on the slide is things like improving diagnostics, supporting patients, managing comorbidities, having ascites and sort of pleural effusion drainage, obviously expediting treatment, expediting MDT decisions, perhaps inpatient transfers sometimes, and you know, the whole, we need to really come up with a plan how we can improve that. Next slide, please. So I think this is the point where I'm handing over to Georgia to do the stakeholder mapping exercise and how we're going to go about it.
Thank you, Aggie. That was beautifully timed. And I think you've laid the scene beautifully as to why NOCA are targeting this intervention. I agree completely with you that the eventual goal, and having spent my entire academic career trying to focus on early diagnosis in primary care, that's the eventual goal. But before we get there, we've, I think, got to take this step by step. So the first step is to try and find these women, and then try and ensure we have this three-pronged. I like to think of this as a bundle, like a sepsis bundle, and that bundle has number of components, but this is what we're trying to finesse now. George is going to talk to us about what the practical components of this QI will be. At the first step, we're going to feed back the results to individuals, and then once we as individuals have received the data, what is it that we're hoping to achieve that people will do? Georgia, yours.
Great, thank you, Sudha. So in the next 10 minutes or so, I just want to talk about the quality improvement intervention and what we've learned so far, and what's the best way to design and implement interventions. So this is a stakeholder mapping, which is actually a strategic process that's being used to identify and actually visualize individuals and groups with a vested interest in a project. So when we are to choose an intervention, we will need the top right people engaged the most. So choosing an intervention that targets them increases the likelihood of the intervention being successful. Then another important tool is creating a process mapping, which is actually about identifying what the problem is and then working backwards to try to break it down into smaller steps. So, we have these women who present as an emergency, and the fact that 40% of them do not receive any treatment. So if we start from the beginning and try to think about the problems across each step, we can see that these women are unwell, have late-stage cancer. There is the postcode lottery as well, with hubs and spokes, which is how the ovarian cancer care is organized. And then, when we are talking about early suspicion of ovarian cancer, diagnosis, which will prompt relevant blood and radiological investigations, these women have inappropriate investigations, and that's sometimes due to the fact that there is poor awareness of ovarian cancer by different secondary care teams. And these women need stabilization. We need to optimize their symptoms, refer them to the MDT quickly, and provide them rehabilitation. And this is where different problems can arise, like late refer to the MDT, and these women keep deteriorating, there is poor rehabilitation, and all this diagnostic uncertainty is causing anxiety for the patients and the family. And then when they are to have an appointment with the relevant teams, there are delays in getting their appointment, and treatment might not be offered to these women, as we sometimes base our treatment decisions on their current performance status rather than the pre-admission one. And then when we're talking about treatment, potential problems are SAC-related, toxicity, and post-op complications. So I think after creating this process mapping, another useful tool is try to analyze each step in this process mapping. So if we start with the emergency admissions and having the problems, we talked about potential interventions to try to address these problems. So increasing awareness of ovarian cancer, providing education to our colleagues in primary care, but also we thought that women should be aware of the hub and spoke systems and how ovarian cancer care is provided, so they can make their own decisions about, where they're gonna go to as an emergency, for example. The next step in terms of suspicion of ovarian cancer, we need to provide education and improve the understanding of the disease and treatment options, highlighting the need for cytology in the investigation step. We need prompt symptom control, and we also need to nominate a local clinical lead for the patient to ensure some sort of accountability, because what we think happens to these patients is that they can get lost within the system, going from team to team without anybody taking responsibility of them. Then they are referred to the MDT, and then some of the potential interventions to address the problems arising at that stage would be having a fast-track pathway from the pathology with an automatic trigger for high-grade serous ovarian cancer. In an ideal world, we would like to have twice weekly MDTs, as these women can deteriorate quite quickly, and providing them a point of contact like the local gynae CNS or the AOS nurse can decrease their anxiety. In terms of the receipt of treatment, we're talking about capacity issues, and a potential intervention that we thought about is having some sort of pooled resources in the region to provide them like a chair to start their first cycle of chemotherapy as soon as possible. And this is something that has happened in Manchester for lung cancer, where the lung cancer service has pooled resources so they can expedite the diagnostic part for lung cancer patients. We need to create fast-track pathway for patients who represent with symptoms such as ascites. Ideally, we would like to increase the availability of inpatient chemotherapy, as sometimes these patients do not leave the hospital at all. Another possible solution that I know that some systems do is having some surgical slots in their surgical diary for ovarian cancer patients. and we also need to focus on rehabilitation, symptom control. So we thought that the ascites workup and so educating on investigations required and highlighting the need for cytology, but also creating a fast-track pathway might be some interventions that people would like to implement. And then the next step in this process would be to create an ideal like patient pathway. So what would like ideally to happen to these patients? And so when they present through emergency and there is suspected ovarian cancer, they need to do some sort of diagnostic workup. And and at Bath, they've created the Fast 5. Miriam, who is a subspec trainee, will talk about that in a bit. And we came up with a similar thing, which is called FILM-B, because it's an acronym and people remember acronyms. And then when the cytology has been sent from the ascites, we thought that potentially creating an alert for high-grade serous ovarian cancer patients to be referred directly to the MDT. And then there is the treatment decisions when most of these patients will not be candidates for primary cytoreductive surgery, so most of them will end up having neoadjuvant chemotherapy and then be considered for interval debulking surgery. We also thought that another pressure point might be patients with recurrent admissions and ascites. So creating like a fast-track pathway from the spokes to the hub might be a potential intervention, and try to prioritize these patients for mainly chemotherapy. And I also wanted to talk a little bit about the timeline of the intervention. So we're still in the first phase when we share best practice and we try to develop a menu of intervention strategies which the participating systems can implement. We try to identify 5 systems that are interested in developing a local process mapping for system diagnosis, and these things need to be done until October 2025, when we will launch the QI intervention and we will introduce the performance indicator in our quarterly dashboard. So the second phase will include developing the pilot study, which will allow regular meetings to support the implementation of the selected interventions. And then we were hoping to deploy the GO2 study in up to 10 sites nationally from March 2026 to December 2026, but we will also focus on sustaining the intervention strategies within the pilot sites and carry out iterative changes when required. And then from December 2026 and onwards, we will start assessing the impact of the intervention, present the results in conferences and academic papers, and hopefully scaling up the study across multiple sites. And all these things will be supported by the quarterly NOCA dashboard, which will provide almost real-time assessment of the performance on that performance indicator. So in terms of the immediate next steps, as I said, we're trying to identify 5 systems interested in participating in the pilot study. We want to work with them for systems diagnosis using a process mapping to build on the above work, and work with them to identify a key pressure point, which we know is not the same for every system. There's no one size fits all, and we will utilize different tools and frameworks from the implementation science, such as the behavioral change wheel model, where we will work with the gynec cancer systems through structured brainstorming meetings. And that was the end of my presentation. So I think we will now move on to sharing some real-world experience and focus on what is working well in the ovarian cancer pathways.
So thank you so much, Georgia. That's really, really exciting. I mean, please don't worry too much about the timelines. I think we accept that these timelines are, I mean, they're sort of idealistic timelines. I think we're more looking at 5 sites who can work with us to do a process mapping until perhaps the end of the year, and then maybe 10 sites where we can launch this intervention, which I think will be a bundle, perhaps next year. I think from the quarterly dashboard, there is a time lag for about 12 months, isn't it, Andrew, to get the data into the quarterly dashboard. But essentially, data on improvement will come through the NatCan spine. But then we'll be launching this, and we hope to really do this like a clinical study protocol. And George has come up with the term "Got You," which I think is a really excellent study title. Andrew, do you want to come in on the data and how far behind, what the time lag to capture it in the quarterly dashboard will be?
So what we're hoping to do with October's quarterly dashboard is push it forward by 9 months to a year in terms of the dates of diagnosis that we're including. So at the moment, we're just pushing forward quarter by 3 months every time we publish each quarter, and that will be what would be happening in July's dashboard, which will include women diagnosed in England up to the end of, so December the 31st, 2023. We'll be hoping to get that pushed forward to maybe September or December 2024 when we publish October's dashboard.
Okay, so the data is will be about 9 months behind, 9 months to 12 months behind. So that's fine. So we now, I'm very pleased to have, so shall we start with BARTS, Saurabh and Rohan. You have fantastic positive outliers, great inspiration. What do you think has worked well for you? Shall I start with Saurabh first in the diagnostic phase, and then we'll speak to Rohan? Because I think this is a point where the surgeons and the oncologists have to work really closely together to try and get things sorted. So Saurabh?
So first of all, thank you for inviting us from BARTS. I think Ravan and Ellie are online. So the first thing what we did a number of years ago was we formed a working group for ovarian cancer, and our aim was to improve the outcomes and also access to treatment. And it's a multidisciplinary group with the same members which are present in the MDT. We've done several little things that have made a big difference. The first thing is we have very good communication between our unit leads and clinicians working in the unit, and open access policy where if they need to discuss a ovarian cancer patient admitted to their unit or they have seen them in clinic, they don't need to wait for the next MDT, and they can call us to discuss the management or what happens next. The other thing we have introduced is Ellie leads our triage meeting every week prior to the MDT, where we ensure that we discuss each patient only once, so we have all the information to make the appropriate management plan. And we have introduced that if somebody sees a patient with suspected ovarian cancer, then they have a biopsy as well as imaging, because regardless of whether they are going for surgery or neoadjuvant chemotherapy, it does help in the management pathway, such that we have also introduced a protected slot in our surgical diary every week, once every week. I mean, once every week is still was a good start a few years ago. We need more than that. But we have one slot every week where we can operate on advanced ovarian cancer. That was to improve the access for primary cytoreduction surgery. So what we do is we do the diagnostics, and if they are suitable to have primary cytoreduction, they go on that slot, and they have a protected pre-admission slot and anesthetic slot pre-book. The benefit of doing the biopsy is even if they get surgery, then we have the diagnosis, and then there is no delay in starting chemotherapy, because as soon as we plan discharge from the hospital, we communicate with our medical oncology team, and they sometimes see them next week, certainly within 1 week of discharge, to talk about chemotherapy and start the adjuvant treatment. Third thing is we have a joint surgical and medical oncology clinic once every week, and that helps patients get in quicker and have a management plan going forward.
Okay.
Anything else I've missed? I think I've covered most points around.
Yeah, Rowan?
Just to add from the chemotherapy side, to also Saurabh's point, so we have very good working relationship with our unit leads, and often if they see a patient who they think is going to be for neoadjuvant chemotherapy who's had admission, they'll just contact us directly, and where they're not able to get them home, we'll arrange an inpatient transfer for chemotherapy. And then the second thing that we did, following a series of cases where we had patients where we couldn't start neoadjuvant chemotherapy in time and they were having multiple admissions, is we've got an agreement with our chemotherapy ward that if we have a patient for neoadjuvant chemotherapy who really urgently needs to start to try and avoid admission, they'll give us a slot the following week, with the acceptance that we don't abuse that, and we really select the cases for it. And actually our chemotherapy unit, as all of them, is massively oversubscribed, but they really do go out of their way to try and to provide that for us, which makes a big difference. And then I think Saurabh's point that the joint clinic really has helped, particularly because we're on different sites, because we give chemotherapy at Barts and surgeries at the Royal London, so we can assess people who are not sure if they might be fit for surgery, but also the post-operative patients, they see us on the same day, so we kind of save a week in terms of planning their chemotherapy. But really the main thing, and because I work on 2 sites, I can speak to the effectiveness at the BART site, is the communication that we have with our unit leads and their ability just to flag the patients to us so that we can start things rolling. And the triage meeting that Ellie introduced has really changed the behaviour with a lot of the unit leads, because they recognise that we'll only discuss the patients once, and I think it's just got everybody into the way of thinking. I think, Georgia, you were talking about a kind of phrase that people start doing the right investigations, and I think it's just brought things forward in terms of timeline.
Thank you. So that's
Yeah.
really helpful.
So I mean, the key things is communication and access, and those 2 little things have helped us a lot.
I'm just going to bring in Ellie for 1 second about talk to me about your triage clinic, and then we can bring Richard in. I mean, clearly these solutions aren't for, I mean, this is all about sharing best practice, really. Your solution will be suitable for some people, but not suitable for others. So, but I think unless we start talking about these things, as you say, small things that make a big difference, somebody has to take the initiative and be proactive about it. So, Ellie, your triage clinic, please.
Sudha, thank you very much. It's an MDT triage meeting. It's not a clinic.
Sorry.
In fact, it's just the day before the MDT meeting. So myself and one of our clinical oncologists, in fact, we run a meeting just with our MDT coordinator. We used to do it with a radiologist, but we realised that we didn't need to waste their time for that meeting. All we do is we review the pro forma of what investigations are available for the meeting to make a judgment on whether or not we have all of the right information available to make a decision about management. So, for example, if a woman's been referred in, this doesn't happen anymore, but previously, before we started it, and this is about helping to educate all of our colleagues that we work with, if a woman being referred to the MDT with an MRI highly suggestive of ovarian cancer, we're not going to be able to make a management decision without a CT chest abdo pelvis. So we would say, you need to request the CT and then we'll discuss her. Now that so we would triage her off the meeting, so she wasn't discussed in MDT that week, and the referring team would need to arrange that further investigation, then bring her back to the MDT when she'd had it all. And we do this for all of the cancer types that come through to the MDT. It's not just the ovary cancers. Works very well for the advanced cervix cancers, where we would choose to do a PET as part of their pre-treatment workup. And you can glance at an MRI and get a very immediate indication of if she's going to need a PET, or if you've done a clinical examination where it's very obvious it's advanced cervix cancer. I'm sorry, I'm moving on to a different subject. But it doesn't just benefit our women with ovary cancer. And when we started the triage meeting, we probably triaged off between 10 and 15 women a week. We discussed between 50 and 60 women a week. And 10 to 15 of them didn't have everything that we needed to make a management decision. Probably now, sometimes we'll have a triage meeting where we don't triage anybody off, or the only ones we triage off are our post-operative pathology review patients where the path isn't ready because it's, the pathologists tell us for this meeting which pathology cases aren't going to be ready. So running that meeting has improved the diagnostic pathway and improved the understanding and education of all of our colleagues that we're working with.
So thank you.
It takes about an hour.
Thank you.
And we do it as two consultants.
Thank you. So I think that's really something that we, Georgia, you're taking notes on you.
Yeah.
Can I bring in now Richard from Manchester? Richard, again, amazing results from the Christies. What has worked well at your end? And I know I'm particularly impressed with Manchester because Manchester's had an interesting history over the years. So, and I know you worked very hard to bring one MDT that is a highly functional MDT. So please tell us.
Okay, so thanks for that. I'm not really going to talk about MDTs. First of all, just to correct, the Manchester data includes both Christie and St Mary's Hospital. I do my clinical work at St Mary's Hospital. I'm not esteemed enough to work at the great Christie.
Sorry, Christie's was a word.
Because that's important, and we come back to that in a minute. There's a lot of overlap with what's already been talked about, but I think just to give you a quick story, and I won't take too long, but I think it's interesting and important. It goes back to about 2018 when we started to have real interest in patients who didn't survive very long. Now, there's clearly an overlap with the emergency presentations here, but that was the group we focused on. And we defined a group of patients who die within about 100 days of diagnosis, and we call them ultra short-term survivors. We did a case control study of that group and matched them with women who lived a lot longer by age, stage, and grade and other bits and pieces. And we pulled out a bunch of facets that really define that group of ultra short-term survivors. And in our model, what comes out is poor performance status, low serum albumin, low hemoglobin, and high platelet count. If you have that combination, your prognosis is not very good. And so we became really interested in what we could try and do to try and improve things for that group, and particularly, could we get them into treatment? So we defined a set of standards. We call it the STOIC protocol, and that was the study we initially did. So it's called the STOIC protocol. It's a 12-point plan which can be instituted as soon as we suspect one of those patients exists. And so we've really tried to empower everybody in both unit level and centre level, the clinical nurse specialists, the junior doctors, consultants, everybody, to be able to start to institute that 12-point plan. And the key bit of it is that there are lots of things to be done in parallel. So we really try and encourage the biopsy to be happening at the same time as the ascites is being drained, at the same time that you're restoring the hemoglobin, at the same time you're putting dietary advice in. You don't need to wait for a dietitian. You can start dietary input by yourself, get on with it, get the dietitian in the next day. And one of the really key points about that was get all this moving and use the MDT as a ratification tool at the end, not as a decision-making tool up front. And that was really fundamental to it. The idea that we could start getting most of this working, because everybody knows what to do. You don't actually need to wait for the MDT to get all this going. What are the risks of it? There are several risks. One, you may start this pathway on somebody who turns out not to have an ovarian cancer. I'm not too worried about that. I don't think it's the end of the world. If they turn out to have a disseminated GI cancer, you probably haven't done them too many disfavors either. You can pass them on to the right team. We also instituted as one of the things is we try and bring patients in centrally. That can be a problem because clearly if they are an inpatient at one of our units, it can be a big thing to bring them in. So I think that bit is a bit that we have revised over time, but as we've empowered our unit leads, in many cases, they've started to do sort of these initiatives locally anyway, so they don't necessarily need to be with us. Now, we started this just for those STOIC patients, that small group of patients who we expected to have a really poor prognosis. And we've continued to audit that group. But the really interesting thing is it's spilled over into everybody else as well. So even women who actually don't fit the STOIC criteria anymore, we tend to employ the STOIC protocol, 12-point plan, get things moving and get it all seamless and try and get the treatment as quickly as possible. I think learning points from it are we've had to work together. We've worked very well with the medical oncology team based at Christie. Gordon Jason instituted it for us at the Christie. We've instituted it at St Mary's, and they're kind of parallel protocols and they work really well. And that's why I wanted to make that distinction, because I think that's really important. 2 hospitals can do it. We've had to work very hard with all of our allied health professionals, so the dietitians, the physios, and so on, to bring them on board, OTs, to get them all working. And we've had to keep reiterating it every now and then to keep that message going. But I think by doing that, I think that's probably why we've had the success that we've had. And that's my opinion.
That's
Thanks.
lovely.
So,
thank you.
Yeah.
Thank you so much. I think we will be emailing you for the Stoic protocol ASAP. So I think that would be really good, because then it will mean that we can send stuff out that has A, worked in a place, but B, if you give people a scaffold, they will do beautiful things with it. One doesn't have to re-initiate the scaffold. So thank you. That's really helpful to hear. I'm now going to bring in Miriam. I mean, our subspec trainees, our fellows, our allied healthcare professionals are absolutely instrumental to making change happen on the ground. Miriam, what have you done at Bath? And tell us about how that's worked.
First of all, thank you so much for inviting me to join you all this evening. I've got involved in all of this relatively recently compared to the rest of the panel, but in Bath, we audited the time from presentation to ED and a diagnosis of ovarian cancer. We found that actually it was 20 to 25 days. This was up to August of 2024. That felt like a really long time, given that when we looked at the timeline, actually there were very minimal delays in terms of patients getting an initial CT abdo-pelvis, and minimal delays actually once we had some tissue. The pathology department were really brilliant. And when we looked at the sort of the timelines, what it seemed like was that patients were admitted and days could go by and nothing was being done to get closer to a diagnosis. And actually the teams were pretty good about putting an MDT referral in, but we're thinking of that as sort of, we'll wait for the MDT discussion before we do any investigations. So we wanted to figure out why this was happening, and spoke to the incoming resident doctors about how confident they were in the investigations that were required as part of the workup for a new suspected ovarian cancer. And the answer was that they weren't confident at all. About a third of them felt confident knowing what blood tests to arrange, similarly about a third knowing what further imaging to get, and none of them felt confident putting an acidic drain in, or even knowing how to organize an acidic drain, or knowing how to organize an image-guided biopsy. So we kind of started a project, part of which was to do with teaching, and we developed this fast track 5 pathway, very similar to Film B. I really like Film B. We tried so hard to come up with an acronym and we couldn't think of one, so we'll probably copy you now. And then the other half was trying to improve the capacity to perform drains, and also the capacity and timeline between a request for an image-guided biopsy and one being performed. So we've done teaching in the fast track pathway at every changeover of resident doctors since August of 2024. We've also started to have a one-stop surgical oncology clinic once a week, where essentially anybody who needs an acidic drain can have one. So they have an acidic drain put in at the start of our clinic at 1:30, and then it comes out at the end of the clinic after either 5 litres of fluid is drained, or you know, the end of the clinic has the clinic is finishing. We've also spoken to the radiology department, and they've agreed that gynecology patients should have access to what was previously a ring-fenced ENT image-guided biopsy slot every weekday morning. So for the patients that remain inpatient, the time delay between an image-guided biopsy being requested and one being performed has significantly dropped. And we've definitely found that the self-reported confidence of residents in knowing what to request has improved, but also the very, very early result when we've re-audited suggests a kind of a halving in the time between presentation and diagnosis. So it's now more like a 10-day delay between the two. The very, very early results, so small numbers.
That's lovely. Thank you. So, I mean, it's really interesting to see how you can deliver a change in pathway, harnessing really trainee enthusiasm and resident doctor enthusiasm. And I think that's a really important thing for us to take away as well, to see how we can motivate, because it's not just us in gynae. I think it's going to be much more broad spectrum across lots of different specialties. So we've heard some really exciting best practice today from BARTS about communication with unit leads, communication across specialties, using the triage, you called it something, not triage process, and it's not a clinic, but it's a triage process before the MDT to make sure everybody gets everything done. And so I will switch off these pings. So that people get into the habit of knowing what to do. Richard's brought in this STOIC protocol, which I think then balances out the diagnostics with the prehabilitation, with the expediting of treatment. And Miriam, you've talked about how one disseminates across to trainees. So lots of people from lots of different specialties will be switched on when they see a woman with carcinomatosis. And I think, Richard, you made a really good point in terms of we may not know what it is, and for some patients we will be supporting people who will go on to have other cancers, but that's okay. It's not the end of the world. And from an individual perspective, actually, that's the kind of thing to do. I now, so we've had fascinating panel. I'm now going to throw the floor open to questions as soon as I can get the tech here to understand what I'm doing. So let me see if we've got questions. Can anyone see the question panel?
I can see the questions, Sudha. Do you want me to read them out?
That would be really helpful. Yeah, because for some reason it's not clicking at my end.
So I think both questions are for BARTS. So with regards to protected slot at BARTS, what is the time from MDT discussion to being operated in the protected slot?
Within 2 weeks. So if we discuss somebody this Wednesday, usually the protected slot is not the next week, the following week.
Although I mean, I suspect most of these patients are so, I mean, the patients we're speaking about are so poorly that a tiny proportion will be ready for primary surgery. Or is that not how you're seeing? Because we're talking about very, very sick people who were actually the balance is between chemotherapy versus best supportive care. And it's that balance to get people quicker through the system. Would that be fair?
True, absolutely. But there's a small proportion where actually they have been admitted and we can operate on them, or there is a need to do an operation, i.e., bowel obstruction, etc. And in those cases, what we've done is we have managed to do them not on the emergency list, but one of our elective lists, moving things around, and we always try to make space for ovary cancer.
No, thank you. What's the weirdly I can't see the questions. Can you go on?
Yeah. The second question is for Ellie. Do you streamline cases for the MDT, such as grade 1 endometrioid endometrial cancer, at your vetting meeting?
To be introduced next week, we have just brought in a process of what's called standard of care. So women with G1, G2, 1A endometrial cancer reported by a gynae-onc pathologist and a gynae-onc radiologist don't have a formal MDT discussion, but have an agreed standard of care management. They still get a documented MDT outcome.
Thank you. I'm going to, I mean, clearly communication with your unit leads is key. How did you achieve it? Because clearly unit leads, we haven't always been brilliant at the BGCS at harnessing the potential of our unit leads, and I've said this many, many times. What's worked? How have you managed to work cohesively with them? And I'll ask I'll ask Richard first, and then the team from BARTS.
It is a good question, so I think it is about continuous working, isn't it, and getting to know people and building relationships. A couple of things I've done over the years. I mean, as many of you know, I moved to Manchester about 11 years ago and didn't really know the environment and didn't know the unit leads around. It wasn't like an infrastructure I'd grown up with. And as part of another project, the MDT work we did, I went round each MDT and physically sat in the room with people on an MDT meeting, and then dialed back into my MDT as part of them. And that's worked really well, because it means you can sit and have a chat before or after they're presenting their cases and that sort of thing, and get to know them. I've been and given formal presentations about this work at a couple of the units to both their consultants and their juniors and their clinical nurse specialists. That's worked really well. And we still do occasionally have drugs company sponsored evenings, educational evenings up here in the Northwest. I don't know whether you all have the same things, but you know, we get together every now and then, not very often, but we've used that forum again to kind of push it as well. So I think it is that constant education dialogue, talking about it, and as I think it was Rowan said, making it very available that people can ring us at any time, and knowing that, you know, the 5 consultants in the centre are very happy to have a phone call. Give us a ring about somebody if you're worried about them. We'll decide whether to leave them with you and you can optimise them there, or whether we're going to transfer them centrally. And as I said, that's something we have done quite a bit, and I think that worked, at least initially, when we were getting things off the ground. And I think then other people got confidence as they built that practice up.
Thank you. I think it's mutual respect, isn't it? And I have to say, I get irritated sometimes. Yeah, I think it's mutual respect, and that's so important, that we respect our colleagues. And then when we respect our colleagues, actually, they're much more likely to work in a productive way. Bart's team?
There is another question, Sudha.
So we'll come back to Bart in a second. What is this exciting question, Georgia?
So it's from Mr. Balega, so I'm gonna unmute him. Mr. Balega? I'm not sure. I'm gonna read the question. He asks, do you have an issue with the philosophy of other teams in managing poorly patients, palliative care and gastro?
Hello, can you hear me now?
Yeah.
Yes, thank you for reading it out. I do, sorry guys, and beautiful presentations, and I'm very keen to see your protocols. We do have some issues in Birmingham. Obviously, it's a different geography compared to London. But we do have problems with pockets of care which are not in line with our philosophy. I can see that everybody here would like to salvage these patients, would like to get them ready for chemotherapy, obviously within reason. But what would you suggest us to consider convincing these ancillary teams, who are very important? You know, these are the teams who admit these patients, and we don't even know about these patients. Do you have any experience?
So I'll take Richard, 1 second. I'll take Rowan first, who looks like she wants to speak, and then I'll come back to you, if that's okay.
I wasn't actually putting my hand up to speak, Sudha, but I think it goes back a bit to the point before, that we've kind of made ourselves available through the acute oncology service teams at our unit hospitals, so that if a patient comes in, if it's not one of the oncologists will see it and feed back to us and bring it back into the MDT, and our unit leads will often be involved to go and see the patient. So I think it's a little bit, I think the point maybe, Miriam, you were saying about raising awareness in the kind of A&E teams and the kind of medical teams, and certainly we've seen more early intervention from them in terms of involving acute oncology and the unit leads for working up these patients. So I think it's a little bit of education, but you're absolutely right there. They're very vital to supporting the patients, but we've been getting involved earlier rather than waiting for a confirmed diagnosis, and I think that's helpful.
Richard, and then Saurabh.
Yeah, Janos, you raise a really good point. I think it's a constant battle, isn't it, that we've all fought against for years, about the nihilistic attitude of many other specialties who don't understand that ovarian cancer, even in its most advanced stages, can be more than salvageable, and patients can actually do really well. How do we deal with it? I think it's really tricky. Apart from the idea of sort of constant messaging and constantly trying to get that out there and talk about it wherever you can, I just wonder whether this is something that one of the charities, Target, for instance, might take on. They've done a fantastic job over the years about education with GPs and in primary care, and they've trained, I don't know what percentage it is now, but it's kind of most of the GPs in the country have been through the ovarian cancer training program. Should we be working with them and asking them to try and develop something similar for emergency care medicine?
Very good point. I think Macmillan would be really really
yeah. But I
they've
think it has to be
become,
ovarian cancer specific, so that we have the right message going out. That ovarian cancer is different from other cancers, and that
yeah.
We want to know about these women. There is something we can do. Please don't be too nihilistic until at least we've had a chance to speak to them and to see where we're up to. Yeah.
Yeah, no, I think Macmillan might be very good at it because their reach into other specialties will be very, very high. So from that perspective,
True.
maybe that's not a bad thing because they're the go-to people for lots and lots of cancers. So it's worth. I mean, we can certainly ping them as, of course, with Target as well because I've worked very closely with them. It's just that, yeah, that's a very good point, Richard. Thank you. Saurabh.
Yeah, thank you. Yeah, no, it's a very good point. I echo what Ravan and Richard said earlier. And what I tend to do is whenever I'm speaking to anybody who's not a part of our MDT, I have to, I'm very forceful that ovarian cancer is not all palliative. And Georgia will know this because we've had chats when she was with us. I get really irritated with the word palliative without even trying any treatment. So it's education, and also I think for the other teams, it's important to know whom to call and whom to discuss patients with. I think if we have that kind of line of communication, then it works very well. Because we do get, when we are consultant on calls for gynae oncology, we get calls from other teams. Like I've had calls from community palliative care teams. I think the message has filtered through that they can call us to discuss our patients or new patients.
Yeah, yes, thank you. I think the idea of working with charities and the idea of persistence,
Yep.
isn't it?
So can you hear me?
Yeah.
So sorry, guys. So in the West Midlands, I'm leading a task force, the Operation Delivery Network, and we for March, for the Ovarian Cancer Awareness Month, we invited them to work with us. They are extremely positive, and they are the fiercest advocates of these patients. And I mentioned, because we have this problem, and I mentioned to them that what about a similar, to the primary care education program? What about a secondary care? And they were very, very keen. So I do feel this needs to be maybe at a higher level, maybe at BGCS level, to collaborate with all the three major ovarian cancer charities, and to have some campaign on this.
Yeah. No, thank you, Anuj. And any other questions, Georgia? Georgia, you're on mute.
Apologies. Last question. Do you have any insights with respect to emergency admissions as to what specialty they are referred to, i.e. general surgery?
Thank you. I think George has been doing some work on that, no?
I mean, yeah, it's part of my PhD. I haven't actually looked at the data properly yet, but this is something that we want to explore, like the pathway of these patients, how, where are they, like why do we not see them?
Yeah. So and whether there have been opportunities over the previous 12 months to spot these people. So the work is in progress. Georgia will present at some point on that topic. Any other questions? No? Okay, so we are at 8 o'clock now. As I said, we've got some enthusiastic and interested sites who pinged us already. There is still space for a couple of sites who would like to work with us to develop this QI intervention, to do the process mapping, and then perhaps to implement this broad bundle of whether that's 12 points as in the STOIC protocol or however the protocol looks like, to implement it and see, so that we can then pilot this and then run it across a larger set of sites. So if you're interested, please ping us. That will be very enthusiastically taken up. So if no one has anyone got any final thoughts on the panel? Okay, so thank you. Oh, Ellie.
I just want to very quickly say one other thing about our triage meeting so people realise it's not just a stop. Also, the thing we introduced at the same time was where any referrals come into the MDT from somebody outside of the core MDT members, so our units and our centre teams, on the day that that referral is received by the MDT coordinator, it is sent to myself and the clinical oncologist who I do the triage meeting with to triage the referral on the day it's received. And that's also helped with us reducing timelines for additional investigations needed, and also reducing timelines of identifying that somebody doesn't need to be discussed in the MDT but needs to be sent on another pathway. So that's part of the triage process.
We're offering a named consultant feedback to every sick
within
patient.
24 hours of us receiving the referral from the into the MDT.
So thank you very much for that, because that's actually a really critical, it's keeping your doors open, isn't it? And having a named person who will then come back to them to say, have you done this, this and this and this, please, because this is important. And perhaps that's something that, and the on-call consultant could do that actually. So it's if you didn't have one person. So so thank you. That's really very helpful, Ellie. So I'm going to wrap this up now with huge thanks to Saurabh, Ellie and Rowan from Bath, Richard from Manchester, Miriam from Bath, and of course our team. We will take this away, we'll digest it, we'll email a couple of you for protocols and things, and then hopefully we'll be able to identify our 5 contenders. As I said, we've got 4 in already, so we just maybe need another couple. And then we will be able to shape up this intervention. Aggie will be presenting more about this at the BGCS conference, and then you will be hearing from us via the usual BGCS channels. So thank you very much indeed for your participation, and I look forward to working with you to develop this further.
Thanks, Sudha. Thanks all.
Thank you. Thank you.
Thanks, Sudha. Thank you all.
Bye, everyone. Bye-bye.